Okay. Yeah, this is Dr. Halasa. I'm the founder of Chronic Disease Prevention and Management. And today we're going to talk about insulin is the soul and cancer is the seed. And we have a book that's been released. Can you mute anybody here who talks on the mic? Please, whoever. Shield, can you take control of the people who are interrupting? Okay.
Sorry.
Yeah. So let's go back to the lecture. Okay. Trying to share the screen, it's not coming up right. Oh, Lord. Okay, now, here we go. So I'm Dr. Halasa. I'm the founder of Chronic Disease Prevention and Management, and we're going to talk about insulin is the soil and cancer is the seed. We have this book is being published today. Hopefully you get the hard copy as well published. And me and my team, Dr. Goldman, Clatz, James, myself, we put together this beautiful book. And it's going to be translated in Arabic, and it's going to be in the hand of the Saudi Arabian royal families, and hopefully soon. And we're looking to send it to RFK as well, because it is alarming. It's warning. It's a problem that the mainstream medicine up to date continue inducing insulin hyperinsulinemia by giving insulin in managing diabetic type 2 with no limits, because they don't think that insulin is a problem. They don't think insulin is a pathogenic. And that needs to be kind of stopped, because the course of complication of diabetic type 2, it can be aggravated with insulin. And so the direction is to wean patients from insulin, already taking insulin, and give them berberine, metformin, possibly GLP-1 to kickstart the whole thing. But that's not enough. As Dr. Stefan will say, hey, we need to also increase the muscle so we can increase the insulin receptors numbers. And I agree with them. Or Dr. Tennell will say, we need to detox the body and avoid exposure to those toxins. Yes, because all those toxins are free radical generator, and they lead to rusting of those receptors, and they lead to insulin resistance, which leads to hyperinsulinemia. But we have something that we can do today, which is educating the mainstream medicine, the endocrinologist, to tell them to wean patients from insulin, and especially in diabetic type 2, and try to increase the insulin sensitivity by all means that we know in integrative medicine, including GLP-1, metformin, 6 hormones, exercise, managing the leaky gut syndrome, detoxing the body. All of this helps to decrease all these pathological free radicals, which are the reason why we have insulin resistance. Think about insulin resistance is rusting of insulin receptors where they don't work. And all those free radical generators can be part of it. But insulin itself that the doctors are giving, thinking that if they lower the sugar, they save the patient. Insulin, it is a free radical generator. It stimulates the NOx enzyme generating free radicals. It compromises the mitochondria, and it leads to release of the free radicals from the mitochondria, pathological ones. And eventually, all those free radicals will cause endothelial dysfunction, oxidizing the insulin receptors, and cause insulin resistance far there, and more hyperinsulinemia. And eventually it leads to atherosclerosis, because once you damage the endothelium, all this oxidized lipids will get inside, leak inside the wall of the blood vessels, and you will end up with inflammation, macrophages will start eating them, the plaques, as we know, the foam, and those they start releasing interleukin-6, transforming growth factor beta, causing more inflammation, and transforming growth factor beta causes fibrosis. So that narrowing of the blood vessels of atherosclerosis is not just fat plaques, oxidized fat plaques. It is fibrosis. It is calcium deposit. And so when we are trying to manage atherosclerosis, don't think, oh, just to stop the production of cholesterol, statin, which is a stupid thing. No, you need to really scrap those flakes and remove those fats. And how you scrap it, cyclodextrin is the answer. Cyclodextrin will go in and load themselves with oxidized LDL and all this plaques and help to reduce them. But is that enough? When decrease inflammation, by cyclodextrin is anti-inflammatory, possibly lower than interleukin-6. But it would be good if you load those cyclodextrin with EDTA, giving it suppository or sublingual or IV, and the EDTA would take the calcium out. What about the fibrosis? Then you need to think about antifibrotic treatments, anything that breaks down the fibrosis. And the best treatment is losartan. I mean, you can use others that inhibit interleukin-6 and the hyperpolarization of Th17, all those polyphenols. But the good ones are losartan. Low dose will be an answer for that as well. I do like losartan. But if anybody knows anything else, supplements that helps to break down the fibrosis, because it's part of management of atherosclerosis. Now, insulin is the culprit. And that is something that most of the doctors have no clue. We think glucose, and we're chasing the wrong guy for many years. You can say from today, almost since medicine is being created, we are chasing glucose and we're measuring glucose. And as long as glucose is low and hemoglobin A1C is low, you're good. And we can do it with insulin. And you can give as much as insulin. That's what we learn in the mainstream medicine. And that's wrong. Because insulin itself is a free radical generator. And once they generate the free radicals, they oxidize the sugar and they become glycans. And yes, those glycans become a free radical generator and perpetuate what insulin started. So a patient can have hyperinsulinemia with normal hemoglobin A1C and normal glucose for 5 and 10 years. Does that mean this patient is healthy? Yes. For the mainstream medicine, oh gosh, you're healthy. Your sugar is good. Your hemoglobin A1C, go home. You're good. You don't have any problems. And they did not check the insulin. And just recently, and I think Dr. Stefan agreed with me, that we have patients with normal hemoglobin A1C, normal glucose, and their insulin is 3 times the normal. And the insulin is causing all the problem. And so when that patient has stroke or has hypertension, by the way, then we say, well, where did this hypertension come from? Why he has stroke? Oh, really? You don't know? Well, because he did not lower that insulin. Insulin generates free radicals. Free radicals, whether directly stimulating NOx enzyme or compromising the mitochondria, causing the mitochondria to release all this pathological free radicals. Constant high pathological free radicals lead to oxidation of the glucose, yes, part of it, and direct oxidation of all the components of your body, rusting your endothelial cells, leading to deposition of the fat, leading to the foam and the plaques, leading to atherosclerosis, leading to releasing of this inflammatory cytokine, interleukin-6 and transforming growth factor, leading to fibrosis, leading to activation of the clotting factors, because interleukin-6 stimulate the clotting and lead to platelet aggregation, and then the patient has stroke. Okay, and now we know. Now, the other thing is that I just mentioned, and I have a book that's going to be released maybe tonight or tomorrow, is that hypertension for many years that we know, and that everybody here know, that 10% in the mainstream medicine up to now, 10% is primary, right? And 10% is secondary, and 90% is primary. Mainstream medicine classify hypertension into primary primary 90% and secondary 10%. And so we know the secondary hypertension. I mean, I'm talking to doctors here, not to the public, right? I'm not good in talking to public, by the way. Dr. Joseph will be the good guy for that. He's very good and eloquent. There's people who can break it down, but I'm talking to the language of doctors, so I'm expecting everybody knows what's primary and secondary. And you know that secondary, we can reverse it, because secondary it could be because of high cortisol, Cushing syndrome. It could be because of Addison disease. It could be because of high aldosterone, adrenal hormonal problem. It could be because of thyroxine, high thyroxine, right? It could be because of coarctation of aorta, and all of this can be fixed, and then your blood pressure will go back. You don't need to give them medication. You can fix it. But primary, they say, well, we don't know reason. We'll just give them vasodilation, and that's 90%. Well, the reality is that recently we find out among those 90%, 80% of them is caused by hyperinsulinemia. So what's that mean? That means we need to reclassify the hypertension to 10% primary and 90% secondary. That's a major change, a breaking through in medicine. Well, Dr. Halasa, you're the only one here who says that. And maybe all the 17 doctors will agree. And that's it. Right? What about the thousands and hundred thousands of the doctors in the entire world? Do they agree with you? Well, if they agree, they're supposed to be changing it in the medical book and CDC or whatever. We don't have that. So how we can change it? How we can get this information out and reclassify hypertension? Well, I'm writing a book, and the book has a foreword that is addressing a letter to President Trump, to Saudi Arabia King, because those are the influencers, and to RFK. And I'm hoping that we can, with our efforts, and I cannot do it by myself. That's why I'm gathering you here. I need you all to join forces and help me to get the message through. Why? Because 2 million of people, 2 million per year of people are dying from the complication of metabolic syndrome, including diabetes and maybe more with hypertension, from stroke and angina and all that. And it's because part of it is because of ignorance and because of this hidden crisis of hyperinsulinemia. And we need to address that. And we need to address it today to save those 2 million people who are dying per year. That's a lot of people dying, right? And a lot of people to save. So for me, it's a mission. Now, how I can get this mission going is writing books and getting CME and attending academies and speaking at the academies. But my one voice will not be enough. That's why I'm gathering you here to help me up how we can get this message through. Now, you can help me with sharing my books, and you can help me with co-authoring with me, and writing books, and you can help me with inviting more doctors to attend the meeting. But yes, we have a problem, and we need to address the metabolic syndrome. And I did reclassify the metabolic syndrome as well into 1 and 2 and 3 and 4. No more pre-diabetic and diabetic. We said, the pre-diabetic, basically, you have hemoglobin A1C and glucose in the borderline, and that's it, right? And then if you have diabetic, it means your sugar and hemoglobin A1C is high. Well, that's wrong. That's not, that does not define exact problem that the patient can have that can be reversed. And so we need to reclassify that into metabolic syndrome stage 1, 2, 3, 4. What's stage 1? Stage 1 is that when your hemoglobin A1C and glucose is normal, but you have high insulin, then that's stage 1. Above 7 or above 10, labs are different. Some of them, they say above 10 is considered abnormal. Some of them, they say above 10. Well, we're going to find it depends from lab to lab. So if that's high, then the patient has a problem. And you can have 5, 10 years of high insulin, normal hemoglobin A1C, normal glucose, and your blood vessels is being ravished by the insulin. and you have high risk of having a stroke. And nobody is recognized as a problem because in the eyes of the endocrinologist, it's normal. But now, today, we know it's a problem. It's stage one, and we need to fix it by increasing the sensitivity of insulin, doing everything: berberine, metformin, a low carb diet, exercise, detox, sex hormone, whatever it takes to increase insulin sensitivity. And then we have stage two. Stage two is like the pre-diabetic. It's where the hemoglobin A1C and glucose on the borderline, and insulin is high. And then we have stage three, when it's full diabetic, when hemoglobin A1C is high, glucose is high, insulin is high. And then stage four, when everything is high and C-peptide is low. That's mean you have beta cell failure, right? So it's very important to measure C-peptides when you are weaning patients from insulin and increasing insulin sensitivity by all the things that we talk about, so you don't completely remove the insulin, because you need some level of insulin. You need to keep it at the normal range. Don't go all the way down where less than 5 or 6. That's not right. We need to keep the normal range of insulin. So that's the lecture. But today we're going to talk more about insulin or hyperinsulinemia that increase the risk of cancer. Okay. And so if hyperinsulinemia increase the risk of cancer, means metabolic syndrome increase the risk of cancer. That means patient who is obese with big belly or visceral fat, he has higher risk of cancer than the lean person. Before, we don't have that. We don't have it that completely published, like, oh, if you are extra weight, you have high risk of cancer. We don't know the mechanism. Now we know. If you have extra weight, you're increasing the risk of having cancer, because extra weight translates into high most of the time, because those fat tissue, when they accumulate with fat, they suffocate the cells and they start releasing interleukin-6, and interleukin-6 leads to increasing the pathological free radicals and leading to insulin resistance. So we expect that the patient would have high insulin. And there's a lot of people who are overweight, and they go to the doctor and say, well, you're completely normal. All your lab is normal. Well, they did not check the insulin is high. And now today we'll say anybody with extra weight, anybody with extra fat, and especially if they have high insulin, they have high risk of having cancer. Maybe that message of having high risk of having cancer with evidence will give us that ambition or that power or that will to start working on that, because nobody wants to have high risk of cancer, right? Maybe, and now we have evidence, and that's what today we're going to talk about, that insulin is a soil. It is the soil that helps the cancer to grow. It's not a direct cause of cancer. No, cancer could be because of genetic SNPs, mutations, but if you have genetic SNPs that leads to cancer, and then you provide the environment that trigger the cancer, then yes, then that environment that is the soil that leads to the cancer to grow, that soil that compromises the immune system, the immune surveillance against cancer, which what insulin does, because insulin shifts the immune system away from cytotoxic T cells and Th1 and compromise the immune surveillance. And if you compromise the immune surveillance, you're going to put the patient at risk, because, you know, we have cancer that is emerging from our body. Hundreds are coming out, but your immune system is cleaning them up. If you compromise that immune system, you're putting yourself at risk. And so that's what we say is the insulin is the soil, is the environment for that cancer to escape the immune surveillance, because hyperinsulinemia compromises the immune system. Hyperinsulinemia lead to the shift of the immune system from Th1 cytotoxic T cells to Th2 and Th17, right? And that leads to increase the risk of cancer. And so we can say insulin is the soil and cancer is the seed. And we need to work on preventing that soil from happening by optimizing the health and increasing the insulin sensitivity and lowering the insulin. Almost 90% of everybody in the street, maybe 80%, and everybody in the street do have hyperinsulinemia, by the way. Anybody has extra fat, there is possibility that he has hyperinsulinemia. And so the whole idea is for us as doctors to take this serious, take this to home, take this to the clinic, and start practicing. Screen your patient with fasting insulin. And if they are high, work on lowering it. And tell them why. Well, because insulin leads to inflammation, insulin leads to cancer, insulin compromises your immune system, put you at risk of infection, right? Once they know why, then especially with the warning of cancer, with scientific evidence, not just, oh, it's causing cancer. No, with scientific evidence, I think this will, we call it cognitive therapy. Same like, in Germany, if they, when they have in the picture on the cigarette, they have a cancer lung, cancer mouth, very ugly. And so you think this is being done just for fun. No, it's being done as a cognitive therapy. So when that person is going to grab that cigarette because he's been addicted to it, what makes him to get the cigarette? Because that increases his dopamine, right? Okay, so they need to put some picture there as a cognitive therapy to lower the dopamine, because we are creatures that we move where the dopamine increase. All your desire, all your next movement, it's all about what makes the dopamine high.
Dr.
Why you're here
Halasa,
sitting in this boring lecture, it's just because it increases your dopamine. And if it does not, you will be leaving. And
Dr.
so,
Halasa, I
yes,
have a
go ahead.
question, quick question. So I understand the insulin resistance part and insulin problem, but before even we get to the insulin resistance, maybe we should look at leptin resistance, because the leptin is the driver for the insulin resistance.
Okay, so that's part of the book of metabolic syndrome. We talked about leptin, and we're going to talk about it. Yes, I agree with you. Insulin resistance leads to the inflammation. Inflammation leads to rusting of all the receptor, leads to leptin resistance. And then leptin resistance, when you have leptin resistance, you have high leptin. Now, leptin is like insulin. It's inflammatory signaling. It's a free radical generator as well. And it's
Right.
compromising the immune system the same like insulin does. Same. But
Yeah.
when you have high leptin, you have the hunger because you have insulin, you have leptin resistant. And so it is part to measure the adiponectin leptin ratio and make sure, or a leptin adiponectin ratio, and make sure it's less than 1, right? Because
Right.
adiponectin works the opposite of leptin. And so, yes, we need to keep this ratio normal, because high leptin means you can stop eating. And it's very important part in consultation of diet. So we're different from nutritionists. Nutritionists will say, eat this and eat that and eat that, but they don't know that, well, they cannot stop eating sugar and craving sugar and stop eating because they have leptin is high. They have leptin resistance. And that makes you go to the kitchen at night and seeking for food. It's something that's like compensatory desire to do it. That desire needs to stop. Now, how we can stop the desire of leptin, and what's the best inhibitor or increase the sensitivity of leptin? What's the best drug that increases the sensitivity of leptin? Is GLP-1s. GLP-1s will lead to satiety, and it will stop that craving. That's why I am okay with recommending GLP-1 to lower the leptin. But when you give GLP-1, I don't want to do it in a mainstream medicine way, because monotherapy sucks and it's not working. First of all, you have all the side effects of the GLP-1, which is gastroparesis, muscle wasting, nausea and vomiting, right? And then after they stop it, they gain the weight, and their metabolic syndrome get even worse worse than when they started, right? So during GLP-1 treatment, you have to give them all the supplements that helps to navigate the side effects of GLP-1. That's very important, including anything that prevent the muscle wasting, exercising, and style, changing your diet style, And if you don't do that, you don't integrate cognitive therapy, you don't integrate, dieting during taking GLP-1, you don't integrate multivitamins and all that stuff, then monotherapy will not work. And so that's something, is going to be part of your management, GLP-1 with integrative medicine, not GLP-1 monotherapy, but with integrative medicine, with health optimization, with exercise, increasing the muscle bulk to increase insulin receptors numbers, and changing your diet style and your lifestyle and your exercise style and your eating style, with some fasting and stop eating snacks and having this kind of 12 hours of no food, at least 12 hours, so your autophagy works and clears up this inflammasomes. See, insulin, one of the problems of insulin, it frees up the cells. They become non-flexible and they stimulate the growth nonstop, including senescent cells and inflammasomes containing cells and cancer cells. And so it's bad when it's high, when it's constantly high. It stops the flexibility of the cells. It stops them from the bad cells from dying. And those inflammasome containing cells, they start secreting all this inflammation, including interleukin-6, and perpetuate the insulin resistance and inflammation, especially the Th17 and Th2, which compromise the immune surveillance against cancer and intracellular infections, whether it's virus or bacteria. So I agree with you about leptin. And that's the difference between you as a physician. You look at those things and you monetize it, and you're trying to tell the patient it's not your fault. It's you have your leptin resistant. That's why you cannot stop eating. But let's go ahead and work on that. And giving them berberine, GLP-1, metformin, things that helps increase sensitivity of leptin and insulin is the goal. And once we explain to the patient the whole thing, it's part of cognitive therapy. I want doctors to break it down to their patients, to explain about everything in a lay or in a public language where they can understand it. Because if you give them all this medical terminology, it's going to be difficult. I'm not that good in breaking it down to a public acceptable, understood language. It needs somebody who has that skill. But I think we agree on that. Now, so that's the topic today. Now, when you compromise the mitochondria by insulin, and you release all these pathological free radicals from the mitochondria, but also you release all these acids, those hydrogen that's being stored in the mitochondria, and you end up with acidosis. And so insulin does inhibit the fatty acid oxidation and burning the fat, and doesn't inhibit the mitochondria Krebs cycle, and it leads to building up of lactic acid. And that lactic acid leads to acidosis. And acidosis itself, as Dr. Joseph James, he likes to talk about acidic train. Yes, the acidosis, it's environment that leads to, it's a good host for cancer to grow. Why? Because acidosis compromises the immune system, causes the immune system to be shifted away from cytotoxic T cells and Th1 to Th17 and Treg or into interleukin or Th2. So the acidosis compromises the immune system, and also acidosis leads to dedifferentiation of the cancers to cancer stem cells. So that acidic environment, we need to get rid from it, and how you do it is by activating the mitochondria. Once you're activating the mitochondria, you reverse acidosis by giving them all this alkaline diet. Now, alkaline diet is not the pH of the diet, is alkaline, but the alkaline diet is diet that activates the mitochondria and activates the Krebs cycle, and so burns the food and lactic acids. Or doing exercise also helps to get rid from all those lactic acid as you're activating the mitochondria when you're exercising. So that's the topic of today. Again, insulin is not a cause of cancer, but it provides the environment for the cancer to grow. It compromises the immune system, compromises the immune surveillance, and but most of the time the cause of the cancer is genetic SNPs. That's true, and those genetic SNPs, whether it's inherited or can be induced by the environmental toxins as well, and all of this can trigger the cancer from happening. But if you have a strong immune surveillance, that cancer will not happen in the beginning. If you have the right diet and your health is optimized, there is no environment for those cancer to emerge. You have a strong immune system to kill it. And that's that's the whole topic of today. Insulin is the soil, and cancer is the seed. Anything else? Everything is good now? Let's go ahead and see this second slide. So why does matter? Critical health challenge we face today is cancer incidence continue to rise globally. Right. And we wonder why. Well, people say it's because of the toxins and chemicals, and our food is toxin with estrogen mimics and microplastic and spike protein, and they start blaming it to all the environmental toxins, which I agree. It's not wrong. It is part of they are a free radical generator. But also, we have something that today we can reverse. I mean, we will try to avoid all these toxins and EMF and chemical toxins and energy toxins that we are being exposed. That's part of the plan. And yes, I don't ignore it. I say, Dr. Teno, you're right. But we need to also consider checking the insulin. Endogenous toxins that leads to or aggravate the cancer or provide the environment to cancer is the same thing. They're free radical generator that can be reversed and can be measured. And all those toxins that we talk about, Dr. Teno, it leads to insulin resistance and it leads to insulin increase. And insulin increase compromises the mitochondria, leading to increase in lactic acid. What's the beauty of lactic acid? When I wrote my book, Metabolic Syndrome, some company reach out to me and they say, Dr. Halasa, you're writing lactic metabolic syndrome, and you're saying the insulin is a culprit, and now we are having a system that measure the lactic acid. And we want you to help us as a medical board advisor to educate the doctors on monitoring indirectly insulin using lactic acid. So they have a marker that same like monitoring glucose, they have monitor for lactic acid, which is the most correlated chemical to insulin increase. And so I'm just telling you that innovation leads to creation and advancing medicine and creation of all those new medical tools that helps us to better and optimize the patient's health and better outcome. So why this matter is because metabolic disease is rising in parallel. It's rising, yes, because nobody checked insulin. It's not part of the mainstream medicine practice. Now it's going to be a screening part. It's more important than glucose, by the way. I will measure insulin before I measure glucose, because I get the glucose normal, hemoglobin A1C normal after the insulin is high. And the pathogenesis of insulin is high is more worse than glucose. Let's say, for example, somebody has normal hemoglobin A1C, normal glucose, but his insulin is 30. And then some other has abnormal hemoglobin A1C, abnormal high glucose, but his insulin is, let's say, 15. Which is more worse? No, the insulin that is high is more worse, because that is the one who stimulates the NOx enzyme, generate the free radicals, causing the silence atherosclerosis disease, cardiovascular disease, silent induction of cancer, or providing that environment for the cancer to grow, silent immune compromisation, and that needs to be taken serious.
May I ask a question, Dr. Halasa?
Go ahead.
This is Dr. Bill Cole. I appreciate the opportunity. I've seen hemoglobin A1Cs of 15, and saying that that's more important than the insulin itself, you're definitely going to become, you're going to go on, kidney dialysis. You're going to be blind. You're going to lose your feet. So hemoglobin's A1Cs are tremendously important to keep track of, in addition to. And another thing, do you know which disease affects half of the entire women in the United States?
So you're saying hemoglobin A1C is more important than insulin?
I said in addition.
Oh yeah, I'm not saying. Listen, I'm not saying hemoglobin A1C is a consequence of high insulin because insulin stimulates the free radicals,
Right,
and then
because
the
it's
free
about a
radicals
5-month average.
oxidize the sugar, and then
Yeah.
the sugar causes the hemoglobin A1C to increase. But why I'm saying insulin is more important than hemoglobin A1C because you have patients who is diabetic type 2 taking insulin, and hemoglobin A1C is normal, glucose is normal, and they have neuropathy, they have gangrene, and they have retinopathy, and they lost their eyes. I have my relative. He's taking 70 international unit of insulin religiously. He's no skipping.
No, but
And his
I'm not saying
hemoglobin
that it's not
A1C is
true.
normal and sugar is normal, but he's deteriorating. Why? It's because of the insulin. So does not mean that hemoglobin is not important, A1C. Hemoglobin A1C is the oxidation of the sugar. But what caused the free radicals and what caused it to increase in the beginning is the insulin. So
Well, I
insulin
think a
measurement of insulin
balanced approach,
is important
all I'm
and
saying is,
prior to measuring hemoglobin A1C and glucose.
well, you don't
Because
want
if
to
I do
do it
that, I can
prior in
prevent it.
conjunction. You have to do things in a balanced approach because you can't just ignore it.
No, I'm not saying ignoring it.
All right. So
That's not the
what's the
term.
number one diagnosis that most women have, half of the United States, that nobody knows about? Do you know what it is?
What half of the women's have?
In the United States
Right.
that nobody's diagnosing,
Go
that
ahead.
causes cancers,
What is that?
and toxins and free radicals.
Right.
Do you know what it is?
No, tell me.
MTHFR. It's a genetic disorder. It has two type of mutations,
Right.
and literally the MTHFR, it accumulates toxins your entire life, especially the heavy metals, and the people that have those literally have the amount of metal in their mouth and everything else, and they don't understand that that is really, really preventable. So something that you might want to look into is MTHFR, because it will really complement what you're saying, because it
Right.
also makes everything so much worse if your body cannot get rid of toxins and heavy metals.
I agree with you. Those are, we call them free radical generators, and all of
But
them can
it's
lead to
but
insulin
it's
resistance.
half of the United States women, half,
Right.
50%, and nobody's testing for
I
it.
mean, is that testing the genetic
Well, it's
SNPs?
both men and women I've seen for the
It is,
MTHFR
Right.
mutation.
but they
Right.
say the women have the predisposition of having the honor of 50%, which is nuts. And I test so many women for it, and it's
Testing
so
the genetic
important.
SNPs you're talking about, or testing the level of it's
No,
called the homo.
you test for MTHFR,
Right. The
and
genetic
that's
SNPs.
the test. So it's really, really
Yeah,
key.
but I
You
want to know
should,
whether what you measure, the genetic SNPs, or there is the byproduct of it. Was it the homocysteine, right?
yeah.
Okay.
Hyperhomocystinemia is a result, but you don't test that. You
Right.
simply test the MTHFR.
I mean,
That's the one that,
you're talking about the genetic SNPs then, right?
yeah. There's two
Right.
tests.
Like C677T and A1298C.
Right,
Right.
exactly.
And the C677T is the one that has a homocysteine issue, but the A1291 or 1281C is more like, clotting during pregnancy. So that's a big one. And like it can cause a lot of miscarriages if they're not on the blood thinner
Yeah.
while they're pregnant.
And all the neurologic disorders with the people
Right.
that accumulate the heavy metals, that eat a lot of fish, or that have the metal in their mouth, it's just horrible. So
Right.
anyway, I thought I might mention that because you might want to look into that, because it really can contribute to the amount of free radicals and problems that especially women and men too, but mostly women can accumulate over their lifetime. Gets worse as they get older.
Right. Right. So we mentioned that all those free radical generators, we're not ignoring them. It's part of the equation. But all those free radical generators can aggravate insulin resistance as well and manifest in form of high insulin. And
Okay, Dr. Halasa, let me add something to what Dr. Kaur said. So when you measure the MTHFR mutation and you find it, the solution I have found is them to give them methylated B vitamins and B12 and methylated folate.
right.
Are there any other treatment that you do besides these two things that you do?
Yeah, let me explain to you. Okay, go ahead, Dr. Ko, if you want to respond.
Absolutely. You have to actually detox the body.
Right.
And
Yeah.
if Colleen's
So
listening, it's really important that you
so
put a lot of, even if it's methylated blue, if it's, ozone, if it's the activated charcoal, there's many ways to do that, but you must try to pull those out of the body. Believe it or not, one of the best results the Romans knew,
Right.
saunas. When you do the saunas to pull all of those toxins out of the cells, because they're not in the blood,
Right.
and those metals, because people can prematurely get the neurologic disorders a lot of
so
times. So yeah,
yeah, I always say that detox is going to be the medicine of today and tomorrow because everybody is toxic.
yeah,
Right.
So
Yeah,
exactly.
Desiree
detoxification is
Biologicals has a good homeopathic comprehensive detox.
Yep.
Right.
That's 8 week treatment, and I usually incorporate that in treating my MTHFR patients.
what do
Right.
you call it?
Um, it's the comprehensive homeopathic detox kit, and it's from Desiree Biologicals.
Right.
Oh, you
Cool.
cannot say
Yeah.
that.
That
Well,
sounds really good.
let me get something here very fast. First of all, detox. There's two kind of toxins. There's fat soluble toxins and water soluble toxins. Water soluble toxins we mastered with EDTA and zeolite and other things that we have. Fat soluble toxins, sauna is good, but the best right now that I know is cyclodextrin, and the only that chemical that helps to detox fat soluble toxins. We're talking about microplastic, petrochemical, Teflon, and all the things that it's fat soluble, xenoestrogens and all that. So that's part of detox. And yes, detox is very critical. And the reason because this is I need you to get this clear. You may have patients does not have the genetic SNPs of MTFR, and still they have this homocysteine high, right? And the reason why the free radicals that is coming from the endogenous insulin toxins or from the exogenous toxins that Dr. Tana is talking about, it can lead those free radicals, it can inhibit the methylation enzymes. And you can see the patients have macrocytic um, anemia, or the red blood cells is big, and it's very clear that they have some, especially when you see them under the microscope, that they have some sort of problem with methylation. So the free radical itself, the pathological, the inflammation, can lead to a problem with the methylations and can change the shapes of the red blood cells. In addition, the inflammation can lead to what we call the inflammatory microcytic anemia, where all the inflammation, especially in the visceral fat, can suck the iron like a sponge and can compromise the synthesis of red blood cells, and they look microcytic anemia, and it's mistakenly giving iron. You don't give iron to those patients because it's inflammatory microcytic anemia. So all of this is very important to know, that this abnormalities that's coming from methylations or that's coming from the iron metabolism, it could be the source of it is insulin resistance. So I see that a lot of doctors, oh, he has microcytic anemia, so I'm going to give him iron. Oh, he has problem with methylations, let's go give him vitamin B12. What's good to give them methyl B12, but understand some of it's not because of the genetic SNPs, or they may have genetic SNPs, but it's aggravated by the inflammation and oxidative stress that's induced by the insulin resistance. All right. And also the insulin resistance, as we know, and insulinemia and high insulin, it leads to deposition of fat in the liver, fatty liver, and then you end up with all this liver enzymes, and people think, oh, he has a problem with his liver, he has hepatitis, let's go ahead and investigate that. And the problem is that the liver is being insulted by the insulin resistance. So those high enzymes is because of insulin resistance. So the focus now is to manage insulin resistance. Or you can see patients having a little bit uric acid high and think, oh, this patient has gout. Let's go ahead and give them allopurinol. Well, this gout, it could be because of those free radicals stimulate the xanthine oxidase and leading to production of extra uric acid, and you think it's being diagnosed with, or he has gout. But the fact is that it's not gout. It's the insulin resistance leading to high uric acid, and that's very important. I like screening cars. They have a little machine that you put it under the car, and then it comes out all the list of the parts of the car would they have a problem, right? And in future, we would have the same thing in biologically. We would have some scanners that, like endothelial function test, ANS, those are scanners. But those scanners of the car parts, they tell you this part, this part, this part, there's a problem in them, right? And maybe those three parts, there's no problem in them. Maybe there's a four part that has a problem that leads to these three parts having problem. And the only way you can know that is using artificial intelligence. When you combine all those 2 or 3 parts as having a problem, the artificial intelligence say it's not because of these 3 parts. It looks that they don't function, but it's because of the fourth part that you're missing. And if you fix that, all those 3 parts will work. Same thing in biology, right? We need to get into the root cause, right? And the root cause is not glucose, it's not hemoglobin, it's the hemoglobin A1C, it's the insulin that's being hidden, and we call it the hidden crisis of 2025. And now we reveal the hidden crisis. It's not hidden anymore. We have 17 doctors here. I need you to proactively start with your clinics and start treating your patients if they have high insulin. So the medicine's blind spot, the shortcoming of modern medicine is focusing on tumor, not the terrain, is treat the disease after structural damage. Is that what will happen? Yes. Most of us, we are proactive, or in other words, reactive, instead of working on preventive. And so we need to be more of preventive side instead of reacting to the event. Why we don't stop the event from happening? You have 5-10 years of high insulin before it manifests in the form of diabetes. And during the 5-10 years, you have this atherosclerosis, you have all the environment that hosts the tumor, that compromise the immune system. So if we focus on that and we lower the insulin and we optimize the health of the body, we can prevent and lower the risk of having tumor and cancer and disease and fibrosis. Because insulin causes fibrosis, by the way. Insulin stimulates the fibrotic cytokines, right? Transforming growth factor beta. And fibrosis, what will happen when you have fibrosis? It's the sign of aging and degeneration, right? Liver, when it's being fibrotic, it loses the parenchyma, and that's how you age. We age because part of it because of the fibrosis, by the way. Or at the age of 90, your body will become fibrotic and they lose their function. And part of it that stimulate the fibrosis, the aging, the induction of cancer, the compromising of the immune system, the atherosclerosis, the stroke, the angina, the gangrene, all this, it's insulin, okay? And so we need to treat disease before the structural damage. And if we ignore the early metabolic drivers, we will end up having all this problem. And sometimes those problems is irreversible, where we pass the line of going back. So from now on, we need to go and actively, not reactively, actively looking to optimize the health. And it starts with one test, insulin level, fasting insulin. And you can do the calculation of HOMA, which is fasting insulin, multiply fasting glucose, divide with 405. It has to be less than 1, and make all your patients less than 1. And if you do that, that's a good monitor. That's a good indication that your health optimization, your integrative therapy approach is working. Okay? Okay, so most of us, as mainstream medicine, we manage the consequence. We are not looking for the cause. And as I said, we have a book that's going to be released, Reclassifying Hypertension, where the primary 90% of hypertension is going to be reclassified into secondary. And what is the majority of hypertension? Think about it. 50 to 80% of hypertension is induced by insulin. Is that a good news? Yes. Is that a bad news for the big pharma who's producing hypertensive drugs? Yes, it's a bad news. But most of those hypertensive drugs are generic, so we're good. But it seems like, this is going to be a dramatic change in the way that we manage hypertension and we manage diabetes. Again, I'm talking here. Without you, working together as a team here to get this information out. It will stay in this computer, stay in this room. It will stay in this Zoom meeting. So I need you to actively invite more doctors in our weekly webinars. We have it on Monday, we have Tuesday, we have also Wednesday. I provide the CME for all of them. And I'm open, my phone is open for doctors for any consultation or helping them with their patients at any time. I involve mainly with, trying to change the outside of the box. I used to be living inside the box, taking patients' care from 6 a.m. to 9. But I'm at the stage I find out I need to change the outside because, if we still inside the box, we become ignorance of the change. And sometimes the change has to be coming from outside. And so I need your help from inside. And inside is that getting more doctors on the board and helping your patients, and then give me more data so we can publish it, we can recognize it, we can come up with better protocol to wean patients from insulin if they have diabetic 2, if they have diabetic or metabolic syndrome, or preventing them from having it by screening the insulin level. So why genetic alone fails? Yeah, I mean, go ahead and you say there's genetic SNPs, he has high risk of cancer, but that's not enough to cause the cancer. You really need to have the environment to compromise the immune system to nourish the cancer in order for the cancer to emerge. All right, so you need to have environment where there is hypoxia. There's environment where you have fibrosis, where it squeeze the blood vessels, preventing red blood cells carrying oxygen to the tissue, and that leads to lactic acidosis. And acidosis is a good environment for the cancer to thrive. And cancer and acidosis leads to also causing abnormal growth of blood vessels that leads to the cancer to metastasize and spread as well. So we need to, understand that it's not about the genetic SNPs that cause the cancer, but also the tumor microenvironment or the environment that leads to cancer needs to be controlled. The insulin leads to compromising the immune system, compromise the immune surveillance, which can lead to cancer to emerge, because we know that we are having cancer every day. We are emerging hundreds of cancer cells, but immune surveillance is taking care of it. If you have genetic SNPs, you have more cancer cells coming out than person who doesn't have genetic SNPs. But if you empower your immune system, then it's possibility that you can prevent those cancer, even if you have genetic SNPs. So the genetic explain the possibility, not the probability. The probability of having cancer if you have the environment that favor the inside or favor the genetic SNPs manifestation. And I think there's a proverb where the genetics is the cocking the gun, and then the environment is shooting the gun, right? There's another term for it. But anyway, so mutation is detected, genetic explain possibility, but not probability. Biology of the host determine the outcome, right? So if your immune system is empowered with your health optimization, with your diet, if you have a strong immune surveillance, then even if you have genetic SNPs, it's possible that you'll not have cancer.
Dr. Halasa?
Yes, go
I'm
ahead.
sorry to interrupt you. In the future, let's not refer to shooting guns. There's enough people getting killed in this country every freaking day with guns that promoting it any further is nuts. So
Okay,
I've
I will
known
take that.
people
It's a
that are killed.
proverb
So
for genetics and
another
environment.
analogy would be better if you don't mind.
Do you have better analogy, Dr. Cole?
Anything that it's just that particular one that I've known people that died, so I prefer if you don't mind.
Sure, Dr. Cole.
Thank you.
But if you have any analogy that we can use, that would be great. So cancer as a systems disease, cancer does not rise from mutation alone. It emerges from failure of the biological train. So when you have the environment of cancer, the cancer will emerge. And environment of the cancer is compromising the immune surveillance, and insulin does that. environment of cancer is angiogenesis, abnormal angiogenesis, abnormal growth of blood vessels that is not healthy, that is fragile, that is leaky. The same like the cancer. Cancer, if you see their blood vessels, which is induced by vascular endothelial growth factor, when insulin stimulate that, too much of it, they grow the blood vessel without maturation, so they become leaky and kinky. What's meaning of leaky and kinky? Kinky means that they will allow the plasma to go in and the glucose nutrition to go in, but they will not allow the immune infiltration or the red blood cells carrying oxygen. So you will have hypoxia, hypoxia acidosis, and you have a hard time for the white blood cells to go in because those blood vessels being kinked. Okay, what other things? Hormonal, right? When you have too much of insulin, hyperinsulinemia, constant and hyperinsulinemia, which will be transformed into insulin growth factor, that leads to constant stimulation of those cancer cells, right? Those mTOR stimulation, including estrogens. Estrogens are the one that stimulate the mTOR. Testosterone will convert to estrogens eventually and leads to stimulation of mTOR, and that leads to prostatic cancer. Most of the blame is not the testosterone for the prostate cancer, but it's because of when it converts to estrogens. And estrogens is very proliferative. It is anti-inflammatory and proliferative. So inflammation and proliferation is not good. Any agent cause stimulation of mTOR, stimulating of NOx enzyme, generation of free radical, you have high risk of cancer. Estrogen does that. What else? Estrogens. Insulin does that. Stimulate the mTOR, stimulate the inflammation, especially when it's high. We're not talking about when it's normal, when it's high. And so those hormones could be the reason, and that's why we need to monitor them and making sure that they are normalized as much as we need. So if you're able to control the microenvironment by optimizing the health of the patients and all these parameters and all those factors that leads to cancer, and you normalize it, then even if you have genetic SNPs of cancer, there's possibility that you will not have cancer. Oh gosh. Okay. Insulin more than glucose. Most powerful anabolic hormone is insulin. Insulin regulates growth and survival. So at normal level, we need it. We need some stimulation of mTOR, right, to keep growing. We need normal physiological free radical, which insulin at normal level, it leads to that physiological free radical spike, which activate your gene and growth. You need that, right? You need that to grow, to make your muscle bigger. You still need insulin to increase insulin receptors. So at normal level, it's good. It helps to make your muscle big. It increases insulin receptors. It's essential for growth. But when it's pathological high, it induces pathological free radicals that cause degeneration, that cause insulin resistance. And that's where we need to lower it back to normal. Okay. So when you have insulin resistance and insulin is not working, what will happen? You will end up with hyperinsulinemia, and then hyperinsulinemia lead to muscle wasting, right? And it leads to fat deposition. So hyperinsulinemia, excess glucose, fuel overload activates the growth signaling, and also it leads to tumor survival. So you don't want to have high constant insulin. We need it normal to keep us growing at the normal space and healthy growth, but high abnormal growth along with pathological free radicals, it means cancer. But insulin is very important. Without insulin, your muscles cannot grow normally. Without insulin, the child cannot grow. We still need that insulin because we need the anabolic effect. So we need to have a cycle of inhibition of mTOR where we get rid and stimulate autophagy. We get rid from the weeds, which is inflammasome and senescent cells and cancer cells, or senescent cells containing cells and cancer cells. And that's the fasting of 12 hours that what does. And then we need to stimulate the mTOR to stimulate those healthy stem cells, right? If you do constantly mTOR inhibition, it's not good, right? Fasting too much, excessive fasting is not good. You end up with cachexia and patient can die. Too much of mTOR like rapamycin, it's not good. Yes, you do autophagy, but you will end up aging because there is nothing to stimulate the growth of the healthy cells. So you need to kill the bad cells by inhibiting the mTOR and then stimulate the healthy cells. But you don't stimulate both. This is what's happening when you're taking snacks every time and don't give a chance for autophagy to work to clean your body. Then all this insulin, when it's high, it stimulates both the bad cells and the good cells. That's what we don't want. We want to kill the bad cells and then cycle it with stimulation of the healthy cells. Yes, and insulin, when you have normal insulin and you have normal sensitivity of insulin, it empowered the immune surveillance, in fact. It polarized the immune system to Th1 cytotoxic T cells to kill cancers. So normal insulin is good, but when it's high and you have insulin resistance, then it's bad. It polarizes the immune system away from Th1 cytotoxic T cells into Th2 and Th17. Okay. So what is the evidence here? We can see insulin signaling pathways, that insulin receptors stimulate the mTOR, stimulate the growth. And think about if somebody has cancer and his insulin is high. In most of patients with cancer, they have insulin high because when they take the chemotherapy is a free radical generator. It causes insulin resistance and their insulin is high. And that insulin high can lead to what? To stimulate the growth of the tumor. Now, one will say, why we're doing insulin shots, to lower the glucose to kill the cancer. That's fine, insulin shots. You're using it as a shot, not constant high, as a spike, and lowering the glucose and starve the cancer. That's different from having high constant insulin that stimulates all the environment factors that favor the cancer, whether it is fibrosis, angiogenesis, acidosis, which leads to differentiation of cancer to cancer stem cells, which leads to polarization of the immune system to Treg and protect the cancer. Insulin does everything that the tumor needs. And so when we manage patients with cancer, we recommend to give them metformin, berberine. We check the insulin, and we're trying to do everything that lower the insulin as much as you can. And it's part of the metabolic oncology treatment. We can say this field is metabolic oncology. So we have the chemotherapy and the radiotherapy. All those people, they focus mainly on destroying the cancer without thinking about changing the tumor microenvironment. Metabolic oncologists like us, we can be metabolic oncologists. If you don't want to give chemotherapy and you say, I want to be supportive, I will change the tumor microenvironment, because just killing the cancer without changing tumor microenvironment is not going to be enough, because the tumor is so smart. I tried that with my dad. When he has cancer, I was focusing on giving him low-dose chemotherapy, giving him photodynamic therapy, and the reality is that the cancer of my dad is wrapped around fibrosis. And that fibrosis squeezed the blood vessels to the point even chemotherapy cannot go in. And oxygen cannot go in. The red blood cells cannot go in. And it's like a fibrotic. That's how they protect themselves. And lack of understanding cancer, which I used to be ignorance at time. I was also, like any mainstream medicine, focusing on how I can kill the cancer with photodynamic. And now I think it's the time to do both. You don't ignore killing the cancer with chemotherapy, especially low dose activate with light or sonodynamic therapy with sonosensitive. But also you need to change the tumor microenvironment to become a hostile environment for the tumor, to break the fibrosis using losartan, to alkaline the environment by using diets that activate the mitochondria and stimulate the Krebs cycle so you can get rid from the excess of lactic acid. is by managing the angiogenesis by giving them Avastin. And what's importantly is to lower the insulin. All right. And if somebody has high insulin, then you need to consider what is the treatment I can increase the insulin sensitivity to lower the insulin. It's very critical because insulin really hijack all the pathways of cancer and makes it in favor of the growth of cancer. So normal level of insulin empower the immune system to fight the cancer. High insulin resistance can lead to immune dysfunction and favor the cancer growth. Okay. Okay, so chronic versus physiological insulin. So we said that physiological, pulsatile, demand-driven, self-limiting, it's good, it's healthy. It seems like free radicals. Pulsatile or free radical, physiological level, and self-limiting is good. You need that spark, right? Think about it, if you don't exercise, what would happen to your muscle? Atrophy. So what does exercise does? Exercise induces physiological free radicals to stimulate the epigenetics, to stimulate the growth factors, to stimulate the growth of the muscles. So if you're lazy and you don't have free radicals, it's not good. You end up with atrophy. Okay. But if you're doing too much of activities and you generate not physiological free, pathological free, stressful activities that leads to pathological free radicals, that leads to lactic acid building up, that's not good. That's actually causing the muscles not to grow, actually causing atrophy to the muscles. So there is some watches they wear, whether you're measuring the lactate or the heart rate variability. And when the heart rate variability is getting lower, not higher with exercise, then you may consider, hey, we need to stop exercise because those exercises degrading, not because it's leading to pathological free radicals. So the exercise has to be physiological to grow the muscles. Same thing with insulin. Insulin physiological empower the immune system, stimulate the growth of the healthy cells and stem cells. So we need that. Then we need it to be dropped so we give a chance to inhibit the mTOR, right, to kill the inflammasome, senescent cells, and cancer cells. So as long as we have this cycling, and I like the day to be lower insulin during the day, and then high insulin when you eat. It goes up at the night, and it helps you to grow. And then you start, you sleep, and then what will happen again? The sugar goes down, and so you have this cycle of insulin pulsing. That's good, but when it's constant high, then indiscriminately you're stimulating everything, including the bad guys. Okay. So hyperinsulinemia is the hidden face. You can have 5 to 10 years high insulin without knowing, including myself, including you, including the people, doctors are here, and they are ravishing your blood vessels because stimulating the NOx, compromise the mitochondria, make you feeling, interfere with your circadian rhythm because it causes inflammation of the brain. And you have problem with sleep, you have fatigue, right? Problem with your cognitive, tired all the time. It could be because you have hyperinsulinemia. And so we need to check it because that can accelerate aging, atherosclerosis, putting you at risk of cancer, and compromise the immune system, and putting you at risk of having infection. And so insulinemia appears before full-blown diabetes. And that's what's happening, Normal glucose, misled all of us. We've been fooled for many years, but not anymore. Today we change. Silent but biologically active. Missed opportunity for prevention. Doctors here, no more missing this opportunity. Today, and we expect you to do better. And we expect you to measure all the fasting insulin for your patients. So insulin as growth amplifier, early on notes, years before diabetes. As we know, it stimulates mTOR, promotes cell progression. It inhibits apoptosis, especially it's not good if it's for inflammasome and senescent cells and cancer cells. Suppress autophagy, so I cannot get rid from those cells containing inflammasomes and cancer cells. So they continue inflamed cells, aging cells, secreting all this inflammatory cytokines, speeding the process of aging, and triggering all the inflammation and cancer and autoimmune and all the problems that we experience. And this led to enhancement of the bad guys, enhancement of survival of the abnormal cells. And that we need to work together to stop that by doing all the strategies to lower the insulin. Not lowering to the point where there's no insulin. We need physiological level of insulin. So very carefully that you don't go below 3 or 5, and say, hey, I'm zeroing the insulin. No, we need physiological level of insulin to stimulate the healthy cells. Insulin increase and insulin growth factor 1 bioavailability, and the hybrid of insulin and insulin growth factor leads to tumor, of course, especially if you have genetic SNPs. It may provide the environment that leads to the tumors to emerge. It has anti-apoptotic synergy with insulin because insulin stimulates the release of insulin growth factor. And it leads to this hormonal growth store. So anybody with high insulin, right? What we call those patients? Patient with normal hemoglobin A1C, normal glucose, normal hemoglobin A1C, normal glucose, but has insulin at 30 or 40. What we call those patients? Not cytokine storm, we call them hormonal growth storm. But hormonal growth storm can lead to cytokine storm or can increase the cytokines, inflammatory cytokines, yes. The patient with insulin resistance and high insulin is an inflamed person. What kind of inflammation? Not the inflammation that protects you from cancer. It's unnecessary inflammation. It's Th17 neutrophils damaging your own tissue, or Th2 and give you all this allergies. That's why people with insulin resistance, you can see that they are scratching. And one would think, are you allergic? Are you allergic to something? Yeah. Well, they're not allergic. They just have insulin resistance. And that allergy is manifest with itching, with mast cell activation syndrome. And anything that pushes the immune system to Th2 and Treg is not good. It puts the patient at risk of having cancer because you are exhausting your immune system for nothing. What neutrophil can do for cancer? Nothing. What Th2 can do? B cells. I mean, the mast cells. Not too much. Actually, mast cells, when it's active, it favors the cancer to grow. So we don't want those inflammation, Th17 to be hyperactive or Th2 to be hyperactive. No. And so insulin is metabolically programming your cells to become less flexible, to grow, not stopping growing, to lose its identity, right? To lose their plasticity. And actually, it causes abnormal neuroplastic changes because of the inflammation of the brain. So when you have pain and you have insulin resistance, you have inflammation, you have microglia inflammations, you have more pain. That's why, a lot of patients say, when I'm fasting and I stop eating sugar, I feel good. Even my pain goes down, right? Because the pain fibers, the neuroplasticity of the brain, which is a lot of fibers that's connected to synapses, can break up when you're fasting and lessen the abnormal hyper neuroplasticity of the pain pathway. So it's part of pain management when you manage the metabolic, when you manage insulin resistant. So the metabolic is shifting to aerobic glycolysis. That's what insulin does. It stops the mitochondria and it leads to glycolysis in the presence of oxygen. They inhibit the mitochondria. Even if you have oxygen, you're breathing oxygen, yeah, but you are breaking the sugar from glycolysis and generating just enough of ATPs, and you don't have enough because you block the mitochondria. You don't produce enough of ATP to keep you alert and awake. So you have just enough of ATP to keep you, and that leads to what? Fatigue, because you don't have much of ATP. The mitochondria is being blocked. Think about your batteries being shut down, right? That's what's happening. And you can look them, they're tired and so tiredness and fatigue could be because what? Of insulin resistance blocking the mitochondria. And the only fuel that we are getting, the ATP we're getting is from the glycolysis. And then you have the acidosis. The acidosis leads to numbness. And also acidosis, as Dr. Joseph likes to say, acidic train, and you start trying to dump those acid, try to get rid from it in the urine. During the process of getting the acids out, you will be wasting magnesium and potassium. So most of the patients with insulin resistance is what they have. They have low magnesium, low potassium. When they have low magnesium and potassium, what they manifest? They manifest cramp. I feel like cramps in my body and pain all over and cramping. It's because of what? Of the hypokalemia, and magnesium is low due to the acidosis caused by the insulin. And so what will happen? Insulin leads to loss of metabolic flexibility, and it gives you that environment that favor the cancer growth. Are we good up to now? Not sleeping? Everybody's excited? Okay, invite your colleagues, and I need you to start working on putting lectures to extend, add more, come up with protocols. I'm just triggering you, teasing you as doctors to come to bring more data, more innovations, so we can learn from you. I'm here to learn from you. We're here for it's doctor to doctor conversation. Okay, it's not doctor to the public. It's different. It's not it's not the highway, my way or the highway. If you feel that there's information, it does not it does not make sense for you, you can go ahead and interrupt me at any time and say, Dr. Halasa, I think you need to fix this or that. I'm okay with it. No problem. I don't want misinformation, and I don't want lectures of the highway, my way or the highway. And most of the platform of education is that way. You have a lecture, and then they are starting teaching, and some information is wrong, and it's misinformed, and doctors learn it wrong, and it harmed the patients. But how we get rid from the misinformation? Not by critiquing or preventing or blocking or hating or kicking out people are critic. No, we need critics. We need debates. And so we can prevent the misinformation. So the misinformation can be treated not by exclusion, not by stigmatism, but by debating and conversation and ethics. During the conversation, you have to have the ethic of the dialogue.
Dr. Halasa,
Yes.
here in San Diego,
Uh-huh.
we have the Scripps Research Institute.
Mm-hmm.
That is an institute to research all the medical theories before they're published.
Okay.
So I can try to share this book
Please do.
some of the members.
The book is out. The Kindle book is out. The hard book copy is coming. It's released already. It's just under review, but I think today now it's there. And then there's a hard cover book of it. I'm going to add more clinical cases in it and then release it. But we have the books, and I'm gonna have more books coming out, which is redefining hypertension. There will be a book for that. And then we have the metabolic syndrome book, which I have the Kindle there, but I'm gonna revise it and even come up with better version of it, which I already wrote it. It just needs to be released. So during this week, we're gonna have 3 books coming up. And so everybody, I want you to buy those books and then read it and then tell me if there's any problem in it, or you see errors, or sometimes I use a lot of artificial intelligence, by the way, and sometimes there's errors from the AI from linking the references to the statements. So I need your feedback so we can upgrade this book. It's not my book, it's all of our books. And then if you want to co-author, you want to add, you want to integrate, you want to be part of this team, just let me know. I'm open to work together as a team. So insulin, as we say, it suppresses the mitochondria. We don't say things without having some chemistry behind it. Some people they say, "Well, you said it suppressed the mitochondria. How?" Well, here's the how. It inhibits the PGC1 alpha signaling, which is very important for mitochondria to function. It leads to inhibition of mitochondrial biogenesis. It increases the pathological free radicals, and it leads to genomic instability. So all of this, when it's high, it's not good. It compromises the mitochondria. And that's the reason it compromises the mitochondria, and mitochondria is not functioning well, and it's leaking the pathological free radical, leaking the hydrogens, ions. It leads to acidosis. It leads to all this pathological free radicals.
As well as the fry eggs.
Induce further insulin resistance because, as we know, pathological free radical rusts those receptors, inhibit those receptors, not just the insulin, but all the receptors, including leptins, including the meioreceptors of your brain. So it blocks your receptors. It blocks, and it leads to hormonal, in general, hormonal dysfunction. Even your testosterone, estrogen receptors, those inflammations blocks them. So inflammation, pathological free radicals blocks the hormones from working because it blocks the receptors from acting. And so now we know why hyperinsulinemia is not good, because it provides the ground for the tumor to grow, and it compromises the immune system so the cancer can emerge. And so loss of mitochondrial fitness and promote oxidative stress and DNA damage. And this is something that we can reverse it by checking the insulin and looking for anything that lower the insulin. So we have something to monetize and monitor the efficacy of the treatment. Now, we can do live continuous monitoring of the insulin level indirectly by measuring the lactic acid. Lactic acid is indirect measurement of insulin resistance. I wish Dr. Joseph here so that we can support his theory or his take of acidic train, and that's through lactic acid. So if you have insulin resistance, you have lactic acid is high. And if we measure lactic acid, whether you can measure lactic acid. Now we have equipments or a system that you put it, same like glucose monitoring, continuous monitoring glucose. We can monitor the tissue lactic acid. It could be spectrophotometer or some way of measuring it. And we can get the dynamic of lactic acids. Insulin resistance leads to acidifying the microenvironment, which is the environment that favor the cancer. It suppresses the immune killing by polarizing the immune system away from Th1 and cytotoxic T cells to Th2 and Th17. And it enhances the invasion, right, of the cancer, and also it stimulates the angiogenesis, which will favor the cancer because those blood vessels are kinky with fibrosis. They've been squeezed, so they allow the infiltration of nutrition and plasma, but prevent the infiltration of the white blood cells and hemoglobin or red blood cells. And when you don't allow the red blood cells to go in carrying oxygen, then you have hypoxia, and hypoxia will compromise the mitochondria further and lead to more acidosis. So you have this vicious circle that favor the growth of the cancer. Okay, so those free radicals that's being generated from activation of NOx enzyme and from compromising the mitochondria definitely leads to the mutations. So one will think, okay, well, cancer caused by genetic steps, but we can say cancer caused by also mutation. And insulin causes increase of free radicals, which can lead to genetic mutations. Or if somebody has genetic SNPs, it will trigger the genetic SNPs to be mutated more. And so can we say insulin can trigger cancer? Possibly. But we need to consider the genetic steps as a factor. And also, we don't need to deny any of the other environmental toxins, which leads to generation of free radicals. So any abnormal pathological source of free radicals can cause cancer or mutations that leads to cancer, especially if you have a background of genetic SNPs. And so the high insulin leads to activation of more of pro-oxidant enzyme expression and inhibit the antioxidants. And when you increase the pro-oxidant and you lower the antioxidant, what will happen to the aging? It speeds and accelerate the aging as well, and it promote genetic instability and cancer. Okay, so again, high insulin compromise the immune system, especially CD8, Th1, natural killer cells. All of this will be compromised, and it will promote the polarization to Th17 and Th2. And that put the patient at risk of having cancer and intracellular pathogens. In addition to that, insulin stimulate the release of vascular endothelial growth factors. Abnormal release leads to abnormal growth of blood vessels, abnormal, kinky ones, leaky ones. And the kinky and leaky ones that favor the cancer, right? The kinky ones means that they don't allow the red blood cells to go in and with white blood cells, and they allow only nutrition. That's exactly where the cancer can grow. And then acidosis that helps to differentiate the cancer stem cells to cancer stem cells, cancer to cancer stem cells. And also the acidosis leads to pushing the immune system to Treg. And if you have too much of Treg, then you're protecting the immune system will look at the cancer. This is self-antigen, and they protect them, right? And the Tregs will secrete cytokines that inhibit the killing of the natural killer cells and the Th cytotoxic T cells to kill the cancer. And so all of this is favoring the cancer growth. Again, cancer insulin leads to stimulation of transforming growth factor beta, which leads to fibrosis. Fibrosis causes the squeezing of the blood vessels, preventing the infiltration of red blood cells, carrying oxygen, which is hypoxia, preventing infiltration of white blood cells, preventing the white blood cells from killing the cancer. And then you end up with this cancer-associated fibroblasts, right? And that's why, giving mebendazole will help to break that, will break down the fibrosis, by the way. That's, the mebendazole interfere with cancer metabolism, but also it inhibit the fibroblast. So that's a good thing to give mebendazole and ivermectin. It does inhibit the cancer-associated fibrosis. And by the way, the most problematic reason of failing of chemotherapy and oncology in managing cancer is the fibrosis, tissue stiffening, because that fibrosis squeeze the blood vessels, preventing the white blood cells from going in and kill, and prevent even the chemotherapy from going in. So that's how much bad is the fibrosis, and that's the reason I failed to save my dad, because I was ignorant at that time. I was not thinking about the cancer-associated fibrosis, and you can see it. His cancer is fibrotic, and it's in the PET scan. You can see it's like a little lamp in his throat, and it's fibrotic. And ignorance is the reason. Now we know that we need to break those fibroses, and you can break it with chemically, and also you can do shockwave, and sonication helps. But don't do shockwave and sonication without chemotherapy to cover that, because also shockwave can break and release the cancer as well. So be smart when you are managing cancer. The pre-tumor niche. So terrain altered before cancer. This terrain favor the cancer, whether it's acidosis, metabolic, immune priming, polarizing the immune system away from cytotoxic T cells, Th1, and natural killer cells. Explain early recurrence. So if somebody has cancer and remission, and then they say, I'm remission, I'm good now, so I can eat anything, and then they start eating sugar, insulin goes up, and then that insulin, it will favor the cancer growth again. Because most of the time, those patients with cancer, they have cancer genetic SNPs. Adding the environmental terrain, what will happen? It will lead that cancer to come out. So it's very important when the patient is in remission on cancer, tell them you still have the SNPs, genetic risk of having cancer. You are in a remission. There is a chance that this cancer will come back, but you can prevent that cancer from back by not providing that cancer any environment that led them to grow, by strengthening your immune surveillance, and don't compromise it with eating sugar and eating junk food and eating toxins. Okay, and that explain early recurrence and explain resistance to therapy. Right? Those cancers mutate. They don't respond anymore to the cancer. And then they have all this fibrosis, and acidosis lead to differentiation to cancer stem cells. Think about it. You have the fibrosis and you have cancer stem cells, and then you have the mutated cancer that emerged that is resistant to all the chemotherapy that's being given. Because those cancer that's coming out, it's not going to be like a cancer before. It's going to be aggressive cancer because they learn the tricks of the chemotherapy that's being given or radiotherapy, and now they know how to evade it. So you taught the cancer how to evade the chemotherapy radiotherapy. And so any cancer that's coming up now, it's going to be very difficult to control. Is that what's happening most of the time when you have the recurrence and the patient fail everything and they die very fast? Okay, so when you have the remission, think about your cancer cells that if they emerge, okay, they are going to be aggressive, mutated, different. And so don't let that happen. By strengthening your immune system and by changing your style of eating and style of your habits of exercising. Okay, so the metabolic pattern appears across cancer, right? Insulin elevation, most of the time patient with cancer, if you see their history and their data and their lab data, especially if they're doing insulin, if they're measuring insulin, you will find the insulin is high. So insulin elevation precedes cancer detection most of the time. Okay, so hyperinsulinemia appear years before imaging or biopsy. So the insulin high, it can provide the environment for the cancer to emerge. And so most of the patients, when they have the cancer, and if you look at the history of their lab, you will see that they have high insulin, okay? During progression, tumor growth tracks and metabolic decline, it worsen insulin resistance and parallel disease advancement. The more the insulin you have, the difficult the cancer to control because the insulin is providing all the environment for the cancer to flourish and become aggressive, okay? And then the survival signal, the outcome improve with insulin control. So if the patient is in remission and you want to continue the remission, then control the insulin. If you stop controlling the insulin and patients start eating anything and everything, then there's a chance that the cancer can recur or can come back. And the cancer will come back, it's going to be very aggressive because the cancer this time learn all the tricks of the chemotherapy that they being suppressed by or killed, and all the radiotherapy suppression. And so now it's going to be aggressive. Okay. So lowering insulin improve the immune surveillance, and it will improve the prognosis as well. Any questions? Are you all getting okay? Case pattern summary, same biology, different organ. You know, all this insulin, high insulin, it could be the reason why all the increase of this cancer incidence is happening, especially the colon cancer, prostate, breast, and lung. There must be something in common. And most of the time, if you have data of these patients with cancer, especially the insulin level, you will see that they have high insulin. So insulin can provide the environment for the cancer to emerge because it compromised the immune system and it will trigger the cancer escape. So standard oncology failed. Treatment target the tumor, but not the terrain. Is that what's happening? The oncologists say, okay, this is the cancer. I'm going to kill the cancer. I'm going to give them chemotherapy to interfere with the metabolism, chemotherapy to increase pathological free radicals to induce apoptosis, and I'm going to give them radiotherapy to cause disruption of the DNA, generate free radicals to kill the cancer. I'm doing photodynamic therapy, doing the same thing, and you're going to do proton therapy, but nobody thinks about the tumor microenvironments. So what the cancer does, cancer will change, so it become mutant to all this chemotherapy effect that you're doing. And also it will change the tumor microenvironment and squeeze the blood vessels, preventing your chemotherapy from going and causing fibrosis. And fibrosis itself can be a shield against the effect of radiotherapy as well. So the cancer will change the tumor microenvironment, form a shield around it to protect it and protect themselves from the immune system. And think about this, okay? If we say you wanna, this is what happened, my ignorance too. When I'm saying I want to go do photodynamic therapy, I want to kill the cancer. Okay. Well, you inject the photosensitizers, and the photosensitizers accumulate the cancer, and then you generate the shoot the light, activate the photosensitizers, generate free radicals, and kill the cancer. Well, here's the thing: the photodynamic will not work if you don't have oxygen, and the cancer will say, "Okay, you're smart. You're feeding me with photosensitizer. That's fine. I'll take it. You're shining me light. Okay, I'll take it." But they squeeze the blood vessels, preventing the oxygen from going in. Now, you excite those electrons of photosensitizers, but there is no oxygen to take them because the cancer is smart. Say, hey, I blocked the oxygen. There's no free radicals to kill me, right? Even the chemotherapy and radiotherapy works better with oxygen. That's why ozone is good. Ozone, well, we are smarter than cancer. Say, okay, you're relying on squeezing to prevent the red blood cells from going in, carrying the oxygen. Okay, you think you're smart? I'm going to do ozone. Ozone dissolve the oxygen in the plasma, and the oxygen will go through with the plasma into the cancer and kill the cancer and escape that squeezing of the blood vessels and preventing red blood cells. Okay, that's fine. You don't want the red blood cells to go in to kill you carrying oxygen. I will take the oxygen, dissolve it in the plasma, and get the oxygen inside your cancer and kill you. So ozone is good. Oxygen therapy is good. And now the chemotherapy patients or doctors or oncologists, they need to understand giving oxygen is a treatment. It helps their radiotherapy and chemotherapy and photodynamic therapy to work. Right? So the reason we fail, because cancer is smart, they squeeze the blood vessels, preventing infiltrating of white blood cells. And also they compromise the immune system. Acidosis leads to polarization of immune system into Treg. A Treg will form a shield around it. They will also activate the platelets, and they form a shield of platelets around it. And all of this will protect the cancer, right? So when we want to treat cancer, what we need to do, we need to reverse that. We need to reverse the fibrosis. We need to slow the angiogenesis. We need to work on that. We need to turn the acidosis. We need to give them oxygen for the chemotherapy, radiotherapy to work. We need to reverse all of that in order to get the cancer killed. We need to change the microenvironment to be hostile environment, and we can do that by metabolic oncologists, which are the integrative doctors, right? So we can change the soil around the cancer to make it a hostile environment for the cancer. Okay. So transforming the soil, that's the target, right? Lowering the insulin will be the first strategy you do. Get this insult out, right? And yes, killing cancer cells, stem cells, and you can do that with mebendazole. You can do that with polyphenols. There is a lot of chemotherapy there for cancer stem cells. You can use low dose of it, loaded cyclase nanoparticle, kill the cancer stem cells. Because cancer stem cells, how it's been evolved. The acidosis causes de-differentiation of cancer to cancer stem cells. The more acidosis it is, the cancer, the more cancer stem cells. And the more the immune system will be moved to Tregs and forming a shield around the cancer. So you need to polarize the immune system to Th1 cytotoxic T cells. How you do that? Anti-PD-L1, anti-CTL4 antibodies. That will help to polarize the immune system. And interferon gamma, but you have to give also what is called thymosin alpha. Thymosin alpha synergistically work like anti-PD-L1, anti-CTLA-4. And then you load them all inside what cyclodextrin and platelets nanoparticle, so you end up with nanoparticles, so you can use less dose, and you can target the pathology, the cancer, versus going everywhere. So loading inside cyclodextrin, loading inside platelets nanoparticle is the way to go. But lowering insulin, how are you lowering insulin? Berberine, metformin, GLP-1. I will use anything to lower the insulin. This is the first thing to do with cancer, okay? Because that's the terrain. That's the insulin use the terrain and change the tumor microenvironment into an environment that hostile. And then when we do that, we can restore the apoptosis, right? Because insulin is the one who stimulates the mTOR. We need to inhibit that, right? And we can stimulate the reactive autophagy, and we can improve the immune system. Well, that's good. If anything that helps to kill cancer stem cells, that's exactly what we need. And there's many things you can put together as a cocktail and feed the cancer. But very important is to open up the fibrosis. You can do that with shockwave, by the way, but you need to do chemotherapy with shockwave, low dose, or photosensitizers, or sonosensitive, or immunotherapy. Don't give shockwave and sono without coverage, so that you can kill the cancer. Lifestyle intervention, very important to lower the insulin. Let's change the lifestyle. One of lifestyle is exercise, increasing your muscles. If you increase the muscles, you increase the number of the receptors, right? Right. Anything that breaks the fibrosis too, and cancer-shaped fibroblast. That's, losartan will be a good answer, but there's many can do the same. And I can help you. If you give me your RGC lab testing or other testing of the cancer sensitivity, and you give me the and I can help you to build the protocols and help you to load drugs inside platelets nanoparticle cyclodextrin, so you can get better results. So low glycemic nutrition, that's good. Exercising and bigger muscles. Intermediate fasting, 12 hours at least of fasting to activate the autophagy, inhibit mTOR. Circadian alignment of your sleep. It's very important, so you can detox the body from all those free radicals during the sleep. It's very important. Sauna, detoxing the body, especially the fat-soluble toxins. Exercising and getting rid from all this lactic acid accumulations, and also increasing the muscle size and increasing the muscle insulin receptors. It requires 6-hormone. You need to normalize it, because 6-hormone increase the insulin sensitivity as well. Low 6-hormone can lead to insulin resistance. So we don't need insulin if we do everything that we are doing as integrative doctors to optimize the health and screen all the free radical generators. Everything. I'm not saying insulin resistance and insulin is the focus, but everything: toxin, mycotoxins, MTFR, whatever source of metabolic or environmental toxins, you need to screen them and patch them and manage them. But I will start with insulin. So when you manage patients, you need to start with more efficient way. And I will start with lowering insulin, and then I will look for other source of free radical generators and patch them and work on them. So metformin, berberine, insulin demand reduction, GLP-1, all of this would help to, those are the pharmacology, help to lower the insulin. And you do it within college, right? So you can do immunotherapy and lowering the insulin, and lowering your sugar, yes, because you lower sugar, you lower the insulin. You lower the recurrent risk with doing that, right? When you lower the insulin and you keep the insulin low after the cancer, you can definitely lower the recurrency. When you lower the insulin, you reduce the fibrosis and the aging and the squeezing of the blood vessels, and you increase the perfusion and oxygenation of the tissue, right? And angiogenesis, if it's normal, it's good, but if it's abnormal, it's bad, right? So a lot of doctors say, "Oh, you're talking about insulin. Insulin is anabolic. It helps to stimulate the growth of blood vessels." Yes, in normal level, it stimulates the growth of normal blood vessels. In high level, it stimulates the growth of bad blood vessels, that actually kinky blood vessels, that actually prevent the red blood cells from going into the tissue and oxygenate the tissue, which can lead to gangrene. So don't get fooled by saying, oh, you know what, insulin is anabolic, it helps to oxygenate, it helps increase the blood vessels into the peripheral tissue, so it actually prevent gangrene. No, that's bullshit. Okay, from now. Sorry, excuse me for my language. Paradigm shift. So this is a paradigm shift. We understand we're not dancing around the fire. Insulin resistance, that's dancing around the fire. Insulin resistance is old school. It's not just insulin, it's the insulin itself. Okay? Insulin needs to be lowered. Insulin high, it's pathogenic. Insulin is high is a free radical generator. Insulin is high is favoring the growth of cancer. And possibly it can trigger the cancer because it induces the free radicals that if patient has genetic SNPs, it will cause the mutation to become more bigger. It generate more cancer cells. We know we're producing cancer cells, like hundreds of cancer cells, and your immune system is destroying it, right? All right. But if you have genetic SNPs, you produce more. So what's that mean? You need to make your immune system strong to overcome that genetic SNPs. And then if you have the free radicals, even the genetic SNPs will be amplified by the free radicals. So that's the reason insulin needs to be, and we need to start. And intervention has to be early, because late intervention can lead to the cancer, right? So from late intervention to tumor-centric care into early intervention. That's what we need. Early intervention and terrain-based medicines, right? That's what we need to do. Reduce the insulin demand and no stimulation, and normalize the insulin. So the insulin, we have enough insulin to stimulate the healthy tissue, not that a lot of insulin to stimulate the pathological cells, the cancer cells, the inflammasome, the senescent cells, the aging, the atherosclerosis, the tumor microenvironment that favor the cancer. It's all insulin. Right. And finally, cancer is the seed, insulin is the soil. Soil is measurable, soil is reversible, prevention become possible, and we need to prevent the cancer from seeding in the beginning by preventing the soil of the cancer from emerging by lowering the insulin, monitoring the insulin, and we hopefully that the device that will monitor the lactate acid, continual monitoring, will be available soon. This is some of the cutting edge innovations that I am entertaining. And if you have any questions, the mic is yours. We're done from the lecture today. And we can, well, let's have another 5-10 minutes for anybody here have questions. Are you sleeping, guys? Hello?
Thank
We
you
are
for the
in the
informative
process
lecture.
we're in the process of digesting all this information. That was amazing. Thank you so much for
Thank you.
all the work you've done.
Thank you, Dr. Ziti, and I really appreciate your support and attending and inviting more doctors to come and everything that you do. I learned a lot from you too. I remember the word that you said, if you stop taking sex hormones, especially at the age of 60 and 80, you will die. And that's true because sex hormone is regenerative molecule. And if you stop it and your regenerative molecule is not there anymore, your cortisone will take over, you become cortisone dominant, and you will degenerate, and you will speed the process of the aging, and you will die early. So, and sex hormone now, the FDA is kind of clearing it and making it is okay. And I will start with feeding your gonads with the precursors of sex hormone, which means feeding it with progesterone, DHEA, prognolone. I will start with that before I give testosterone and estrogen. I mean, if your gonads is not producing anymore, or your pituitary is not producing enough to stimulate the gonads, I'll try to stimulate both the pituitary gland. We're using some peptides called something is called KISS peptide or something, and eclomorphine or anything, and then help to feed your gonads with all these precursors, which is the DHEA, prognolone, and progesterone. And then if that doesn't work, I will start giving them, but after and continue giving them things that feeds the so that I will not have what we call gonadal atrophy. Because if you have gonadal atrophy from giving exogenous sex hormone, then you'll be relying on those, and your gonads will not be effectively reactivated produce anymore because it will have atrophy, fibrosis, due to lack of stimulation. And sometimes it's irreversible. There is some reversibility, but it's not complete. So my advice is to feed your gonads as much as you can. My dad and my uncles, they used to cut the testicle of the lambs when they slaughter it, and the cows, and they used to cook it and eat it as a source of 6-hormone precursors to feed their gonads so they can produce. And something I think it's the right natural way of getting 6-hormone precursors into your body. Something you may consider that too, and especially when you go above 50. Any other questions? And 6-hormone help to increase insulin sensitivity, which means if it increases insulin sensitivity and lower the insulin need, that's mean 6-hormone will help us to prevent us from having cancer. But again, endogenous 6-hormone is the first thing you need to stimulate or promote in your patients. Any other questions? Intranasal progesterone is a good way. I like to give it to patients with difficulty of sleeping, and we have very nice progesterone intranasal. So loaded with cyclodextrin. Any questions? Are we good? We can conclude the meeting
Yes.
tonight.
This was very good. Thank you.
Yeah, Happy New Year for everybody. And looking forward to see you next Monday if we don't have, I don't know. But normally we do every Monday unless there's a holiday or weekend or some things that. But see you next Monday.
That's
Happy
good. Thank you
holidays.
Good night.
so much.
Bye.